Okay, let's set a scene for you. You go in for a chest CT scan.
Right.
Maybe it's for lung screening, maybe a persistent cough. You're on the table, the machine does its thing, and that's that.
And then the radiologist is scrolling through the images. They're looking at the lungs, the heart, the spine.
The usual suspects.
Exactly. And suddenly, something shows up. But it's not in the chest cavity. It's in the breast tissue, right at the edge of the scan.
And this isn't some rare 1 in a million thing. Our sources say incidental breast findings happen in up to 8% of all chest CTs.
8%. That's a huge number. And the really critical part, the part that got our attention, is what those findings turn out to be.
Yeah, the stats are pretty sobering. Depending on the study, breast cancer can account for anywhere from 9% to, well, a staggering 61% of these incidental masses.
And if you narrow it down to just lung cancer screening CT, the data is even sharper. About 1 in every 8 of those incidental findings is a breast cancer.
So you walk in for one thing, and you could be walking out with a completely different life-changing diagnosis. That's why we're doing this deep dive. We're getting into the expert radiology literature that guides interpreters on this exact scenario.
Our mission today is to unpack all of this. We'll cover the anatomy you can see on CT, how to tell the difference between benign lookalikes and truly suspicious lesions.
And then get into the really complex stuff, like the post-treatment breast, which is a whole different rule book.
It really does.
Okay, so let's start at the beginning, the fundamentals. What's the basic geography we're working with on a chest CT?
You need your landmarks. There are about 6 key structures. On the surface, you have the nipple areolar complex.
Okay.
Then you go deeper to the ducts, and then the fibroglandular zone. That's the working part of the breast.
And that's all held in place by something, right?
By Cooper's ligaments. Then you have a layer of fat, the retromammary fat, separating all that from the chest wall muscle.
Which is the pectoralis major.
That's the one. Those 6 structures, that's our map.
So if a radiologist spots a little area of concern, how do they describe its location so a specialist can find it later with, say, an ultrasound?
It's all about clock face localization, just like in standard breast imaging.
So they'd say something like upper outer quadrant at 10 o'clock.
Exactly. 10 o'clock, and then they'll give a radial distance from the nipple.
But this is where it gets tricky, isn't it? The localization challenge.
It's a huge hurdle. Think about it. For a chest CT, you are lying flat on your back.
Right.
So the breast tissue naturally shifts, kind of laterally and back. But for a mammogram, you're usually upright.
So gravity is pulling everything in a completely different direction.
Completely different. Trying to correlate that spot between the 2 scans is a real skill. It's like a 3D puzzle where the pieces move.
And if that wasn't hard enough, there are also these anatomical variants that can look just like tumors.
Yes, the benign lookalikes. 2 big ones trip people up on axial scans.
What's the first one?
The sternalis muscles. They're these little muscle variants that run right along the breastbone. On a single CT slice, they can look just like a suspicious little mass.
So you could see a round density and immediately flag it. What's the other one?
The axillary muscular arches. These are just bits of muscle stretching from the pectoralis to the arm muscles.
And they get mistaken for what?
Enlarged lymph nodes. Lymphadenopathy.
So how does an expert tell the difference between a normal bit of muscle and a potentially dangerous finding?
This is the real teaching point from the sources. You have to use the coronal views.
The front-on view.
Right. Because on that axial slice, the muscle might look round. But on the coronal view, you see its true shape. It's long and linear, like a muscle should be.
And that immediately tells you it's not a round, suspicious mass or lymph node.
Instantly. It's a simple trick that avoids a lot of unnecessary workup.
Okay, so we've got our map, and we know to watch out for lookalikes. Let's talk about the tissue itself, specifically breast density. This has massive implications.
Huge implications. Medically and, legally. Density is just the ratio of that white fibroglandular tissue to the darker fat.
And dense tissue has a dual risk, correct?
That's right. 2 big problems. 1, it can hide cancers on a mammogram. It's like trying to find a snowman in a snowstorm.
And 2.
2, it's an independent risk factor for getting breast cancer in the first place.
Now, we usually think of density as a mammogram finding, but the source material made a really interesting point about CT.
Yeah, this is fascinating. Studies have shown that CT is perfectly good at assessing breast density. The assessments are very consistent with mammography.
But there's a key advantage to CT.
A major one. The inter-observer agreement is better with CT.
What does that mean exactly?
It means if you show the same CT to 2 different radiologists, they're more likely to agree on the density score than if you show them the same mammogram. It's more objective.
Wait a second. So there's a law in 38 states that says you have to tell a patient if they have dense breasts on a mammogram. But CT, which gives us a more reliable and consistent reading on that exact same finding, isn't covered by that legislation at all.
That is the disconnect. You have this robust, consistent data from the CT, but the notification laws just haven't caught up. It's a really interesting gap.
That is something to think about. Okay, let's pivot to the flow of disease. The lymphatics. The axilla is ground zero here.
Absolutely. Somewhere between 75 and 90% of the breast's lymphatic fluid drains right to the axillary lymph nodes.
The armpit.
The armpit. They're divided into levels 1, 2, and 3, and also include the Rotter space nodes, which are tucked between the pec muscles.
And when we look at those nodes, there's another major difference between how CT and ultrasound measure them, isn't there?
Yes, and this causes a lot of confusion. On CT, the standard for a suspicious node is a short axis diameter greater than 10 millimeters.
The short axis, not the long one.
Right, because a cancerous node tends to grow weirdly, eccentrically, making the short axis a more reliable measure of true enlargement.
And ultrasound.
Ultrasound uses a totally different metric. It looks at the thickness of the outer layer, the cortex. Anything 3 millimeters or more is considered suspicious.
That's a huge difference in approach. So if you're only using the CT measurement, you're probably less sensitive.
You are. It's well established that CT is less sensitive and specific for finding metastases in nodes compared to a dedicated ultrasound.
Which means context is everything.
Everything. For instance, we saw a lot of reactive lymphadenopathy after the COVID vaccines. Nodes would look big on CT.
But they weren't cancerous.
No. In many cases, they were back to normal in about 4 months. The takeaway is you can't just see a big node and jump to conclusions. You have to ask about recent vaccinations or infections before you start a big workup.
A good medical history is key. Okay, let's get to the lesions themselves, the masses. The first problem is just language.
The lexicon mismatch. In breast imaging, we use BI raids. A mass is a 3D lesion you can see in 2 different views.
But thoracic imagers, the lung guys, use a different definition.
They do. For them, a mass is just anything bigger than 3 centimeters.
And there's that one word that gets used in chest imaging all the time but shouldn't be used for breast findings.
Nodule. You hear it constantly for the lungs. It's not a BI or A's term for the breast.
Yeah.
We have to be careful to translate.
So when we see a mass on CT, what are the features that make you think benign versus malignant?
We're looking at a few things. We lean towards benign if it's round or oval with really smooth circumscribed margins.
What else?
If it's been stable for at least 2 years, or if it contains fat, or if it shows very little enhancement after contrast.
Let's talk about enhancement. You mentioned a specific number.
Yes, we measure it in Hounsfield units, or HU. If the lesion's brightness increases by less than 33 HU from the non-contrast to the contrast scan, that's a good sign.
And what are the red flags? What screams malignancy?
Irregular margins.
Yeah.
Lobulated. Or worse, spiculated, that classic starburst pattern.
Okay.
Also, if it has heterogeneous, messy-looking insides. If it's new or growing, and of course if it enhances more than that 33 HU threshold.
And our sources had a great case that put all those features together.
They did. A 72-year-old woman with Lynch syndrome. Her staging CT showed this enhancing mass with clearly irregular margins.
All the red flags.
All of them. They followed up with a PT-CT, and it was intensely FDG avid. It was just lighting up, soaking up that radioactive sugar.
And a clear sign of aggressive metabolic activity.
Exactly. And that led to the diagnosis.
Yeah.
Invasive ductal carcinoma. It shows how those features really paint a picture.
So that combination is clearly actionable. What about asymmetries, where it's not a distinct mass, just tissue that looks different?
Here, the term to know is developing asymmetry. That means it's new, it's growing, or it's just more obvious than it was on the last scan.
And that's a big deal.
It's the biggest red flag in this category. It carries a 12 to 15% risk of cancer and always needs a workup.
As opposed to just some stable asymmetric tissue that has fat mixed in.
Which is usually just a normal variant. Benign.
And what about changes to the skin?
If you see symmetric skin thickening on both sides, it's often something systemic, like edema from kidney failure or even just pregnancy. But if it's non-symmetric, unilateral skin thickening or architectural distortion, that favors malignancy. That needs to be checked out.
And we should probably mention male breast findings, too.
Definitely. Male breast cancer is rare, but gynecomastia, that's benign tissue growth, is super common. Affects about 60% of men over 44.
And that can be tricky because it can be asymmetric.
Right, and it can be triggered by medications. There was a case of a man who started spironolactone, a common blood pressure drug.
And what happened?
He developed rapid gynecomastia. It even looked a little hot on a PT-CT, which could mimic cancer. But knowing the medication history explained everything.
It just shows how vital that clinical context is. Okay, let's move to our final and maybe most complex area, the post-surgical breast. This changes everything.
It fundamentally resets the baseline. When you're looking at implants, you first need to know what they're made of.
Which you can tell by the Hounsfield units.
Exactly. Saline is basically water, so it measures around 2 HU.
Huh.
You can often see the little high-density fill valve, too.
And silicone is much denser.
Much denser, over 50 HU.
Mm.
And we also look at whether it's behind the muscle retropectoral or in front of it.
The big fear with implants is always rupture. How does that look on CT?
Well, a saline rupture is usually obvious. The implant just collapses. You don't need a CT.
But silicone is different.
Silicone is more subtle. If it's an intracapsular rupture, meaning the leak is still contained inside that fibrous capsule, the body forms.
You might see that classic sign.
The linguine sign is a fantastic description. You literally see the collapsed, wavy implant shell floating inside the silicone, like a bag of pasta.
Wow. And what about when it leaks out into the breast tissue?
That's an extracapsular rupture. And here's the absolute key takeaway for anyone listening.
Okay.
That leaked silicone can look like a mass or a lymph node. But on a non-contrast CT, the silicone will be high attenuation, much brighter than normal tissue. That's how you tell them apart.
That's a critical pearl. We also have to talk about implant-associated lymphoma, BI-ALCL.
A very serious, though rare, complication. And on CT, the red flag is all about timing.
What do you mean?
We're looking for a chronic, late-onset fluid collection around the implant, something that develops months or, more commonly, years after the surgery.
So fluid right after surgery is normal?
A seroma, a hematoma, sure. But a new fluid collection 2 years later, even if it doesn't look particularly nasty, that is a major red flag for lymphoma and needs investigation.
It really shows the power of CT for long-term surveillance.
It does.
And what about reconstruction with a patient's own tissue, like a TRAM or DE plat from the abdomen?
The baseline there should be mostly fat attenuation on CT, since that's what's moved. But a very common complication is fat necrosis.
And how does that present?
Initially, as some hazy, fuzzy-looking areas in the fat. Then, over about 6 to 12 months, you develop calcifications. It's benign, but we have to recognize it.
And finally, what about local cancer recurrence?
The rate is about 1 to 2% per year for the first 5 years. On CT, you're looking for new, enhancing nodules right along the edge of the flap or in the surgical bed. CT is actually very good at spotting this.
We've covered so much ground here. Let's try to boil it down. What's the final management algorithm? What are the absolute red flags on a chest CT that demand a referral?
You're looking for any new or growing mass, especially if it has those irregular or spiculated margins.
And high enhancement?
And high enhancement, that 33 HU jump or more. Also, any unilateral skin thickening, a developing asymmetry, or new suspicious axillary lymph nodes.
Those are the things that trigger the workup.
Those must be investigated.
Yeah.
For everything else, stability is key. If you can show it's been there and unchanged for 2 years or more, you can generally be reassured.
So that longitudinal data from serial CTs is invaluable.
Totally invaluable.
Before we sign off, I want to circle back to something we touched on earlier, that disparity around breast density. We have laws in 38 states mandating that patients be notified about dense breasts found on mammograms. But we've just established that CT is just as good, if not more consistent, at assessing density.
And yet, no notification requirement exists for CT. It raises a really significant public health question, doesn't it?
It does. And here's the final thought for you to take away. As our imaging technology gets better and better, should these mandatory notifications expand? Should a finding on a high-resolution scan like CT trigger the same conversation about density as a mammogram? Or is the complexity of managing all these incidental findings just too high outside of that dedicated breast imaging world?
The technology is definitely ahead of the policy right now.
And that's something for all of us to mull over.